This meeting, which goes for an hour. It's a grand round that the University of Melbourne has been collaborating with St Vincent's Health Melbourne for well over a year now. We have 4 of these a year, sustainable healthcare grand rounds that are open invitation to all who are interested. I'd like to begin by acknowledging the traditional owners of the land. For me, it's the Wurundjeri people of the Kulin Nation, and pay my respects to their elders, past and present. And also to acknowledge their true stewardship, custodianship of land and country for millennia, and that absolute connection between healthy lands and healthy people. So it's a great pleasure today. We have a fantastic topic, and thank you all for joining us. We're really going to nut out the healthcare sustainability and resilience model from the Australian Commission Safety and Quality in Healthcare that was only published several months ago, the final module. There's been a draft module available for about the last year and a half. So really important coming from the Commission. And we have the Commission first, and then we have Mercy Health, who are going to provide some of their reflections and experiences on the module. So hopefully a very practical and informative hour for us all. So without further ado, James Caddy is our first presenter today. He leads the work on the Australian Commission on Safety and Quality in Healthcare's Sustainability and Resilience module. And he's worked across several national health portfolio agencies, including the Australian Institute of Health and Welfare and the Independent Health and Aged Care Pricing Authority. They're all very big worded titles. Has years of experience working in public and private hospitals also across Australia. So thank you very much, James, for presenting today. And we've decided we're going to have the 2 presenters first up, and then hopefully we'll have time for questions at the end. So I'm sure there'll be a lot of interest and hopefully a few good questions and discussions around this topic. Thank you.
Thanks, Eugenie, and thanks for all of your support as well. We've known each other for a bit of a while, so it's great to be here. So I'd also like to acknowledge the Aboriginal and Torres Strait Islander people. We're on Gadigal land in the Commission, and they also play a really important part of the leadership in this space as well. So really important to acknowledge and also bring that knowledge into what we're trying to do with this work today. So climate change and healthcare. So I'm going to assume that a lot of people on the call are going to know what I'm going to be talking about with this. So I'm not going to go into a huge amount of detail, but I think it's useful to sort of set a bit of a context to why the Commission's working in this space and what we're trying to address. So this lovely clear picture from the WHO really sort of hits home that climate change impacts the healthcare system through health risks and really affects those health outcomes. The insidious part here, and maybe it's proportional, but we can also see that on the right-hand side of that picture that we've also got healthcare adding to that problem as well. So by not addressing and not sort of dealing with the problem that we have as an impact as a sector, we're contributing to our own future workload, and we know that some of this stuff isn't going away. So it makes a lot of sense to start thinking about what we might need to be doing in our health systems, in our organisations, and in the delivery of care about how we're responding to the situation that's unfolding. So environmental sustainability, when we're talking about this, we're trying to be conscious of the fact that every resource in healthcare, not just the physical things that are illustrated by the life cycle here, but also resources in terms of clinician time, effort, infrastructure, everything has a history. And so we know that by using those, we are creating or at least supporting further impact on the environment. When we're talking about environmental sustainability, we're trying to look at where the appropriate and evidence-based usage of resources should be in healthcare. And then when we're looking at the environmental impact, we know that we have to use resources because we can't say no to healthcare. It's an important human right, but there is an impact from when we are delivering healthcare. on the right-hand side, after those sort of spotlight triangle thingies, we've got the sort of principles that sort of underline or I suppose overarch what we're trying to talk about with environmental sustainability, which is around prevention being key. So avoiding needing any of it in the first place. So that sort of reduces some of that life cycle and the emissions from the earlier side of that life cycle. Ensuring that the systems support appropriate care so that we're driving evidence-based care, and we're not necessarily leaving some of those systems that might have worked sort of 10, 15 years ago, or those models of care, those pathways of care. Evidence evolves all the time, and we know that that's a difficult thing to keep up with, but it's important that we're ensuring that those the way we're delivering care is evidence-based to make sure that we're reducing waste and evaluating models of care to reduce impact. So can we be doing something to achieve the same goal with less of an impact? And so that sort of looks at some of your virtual models of care or your models of care that are sort of closer to home, such as hospital in the home, and reducing the impact from waste and being conscious that certain types of waste have different levels of impact on the environment, both close to home and further. And we've got a lot of control in this space. So some of these, I think some of the ideas that come out when we're talking about sustainability, someone else is going to rescue us, someone else is going to do this stuff. This is squarely in the arena where we can have influence as well. Even though it might not be immediately obvious. So we'll talk about some of that as well. And then we've got this really bad environmental determinants of health that sort of continually undermines us if we're only paying attention to one of these things as well. So by not paying attention to our impact on the environment, we're generating a problem further in the future. When we're talking about climate resilience in healthcare, we're primarily sort of talking about the risk factors or the factors that influence health. And so that comes through the environment. This is a nice sort of snapshot of something from the Lancet Countdown. I really enjoy it because it looks at things further than just the medical model, which is what we're really used to. So it rounds it out with some of those psychosocial factors, but also the practical factors that sometimes need to be considered when we're discharging patients or we're expecting patients to stay healthy in their own environment. So some of this looks at making sure that we're incorporating those risks into our approaches to design of healthcare, but also the way that we're interacting and investigating with people to make sure that we understand that, you know, maybe we are discharging a patient that doesn't have the ability to keep their medicine safe or cool enough. Maybe they don't have the ability to access further care. And when we're looking at climate change is going to be turning the dial up on a lot of these things that sort of set to disrupt our ability to access it. So being conscious of these specific risk factors is going to be more and more important as we continue. Safety and quality in climate change. So how does safety and quality fit into this big picture, and where did the idea for the module come from? So we started just after the interim Australian Centre for Disease Control, which is great that they're getting up so we don't have to call them the IACDC. They published the National Health and Climate Strategy, and shortly after, the Commission worked with them and the Council of Presidents of Medical Colleges to come up with a joint statement on what it is we're trying to achieve when it comes to sustainable healthcare. And with those, we put together 3 principles adapted from the UK principles of sustainability. And so essentially it mirrors that previous slide around prevention, making sure that we're improving health while reducing demand and associated emissions, minimizing harmful and wasteful care and using that sort of evidence base to navigate that space, and minimizing impact from high quality care. So once we've done all we can in prevention, made sure that we're reducing the harmful and wasteful care, that final step is really looking at what other options we've got to providing to care to people that doesn't have the same amount of impact. So some examples, I think examples are really useful. Sometimes we sort of put these principles up there and we don't say what we mean by them. I'm hoping that a lot of these examples are also really obvious to people in connecting them, but also within the space of what they can actually control or get involved in their own organizations. So infection prevention control, we've heard of a number of people pairing existing initiatives with sustainable initiatives, and a number of these are the Gloves Off campaign. So while trying to focus on hand hygiene, making sure that there is an element of when we're using gloves, making sure that we're using them appropriately, but if we need to use them at all, and matching that to an existing framework, such as the 5 hand hygiene moments. Antimicrobial stewardship should be really obvious, but if it's not, it's around reducing medicines when they're not required. Because of there's specifically with antimicrobial stewardship, there's a global impact that happens when we're not using those medicines. But when we're also using medicines that we shouldn't, that might put us or our patients in harm's way. And so we'll talk about polypharmacy in the next slide, I think. And reducing readmissions. So one of the most sustainable things you can do is that prevention, but preventing a readmission by making sure that someone is going to be okay after we've discharged them, either to a service or to home, and taking into account the factors that might impact those readmissions as well. Which I think also, and so does everything with prevention, requires a little bit of person-centered tailored care. So making sure that we're paying attention to the person rather than treating them like another generic object on a conveyor belt, really trying to understand their situation, their factors, and addressing that so we're not getting those readmissions. And again, a sustainability issue, like it affects impact on the environment and workforce. When we're looking at minimising harmful and wasteful care, we're looking at healthcare variation. So healthcare variation, a number of these are already covered in the sort of requirements for hospitals under the National Safety Quality Health Service standards, which is where we sort of borrowed some of this framing for the module as well. Connected care, so it's really important that clinical information is available, at the point of care. So we're not duplicating the sorts of resources that we're already using because that information exists elsewhere, but it's just not available to us at the point of care. But also so that it makes sense for the person when they're out journeying through the health system that's not our organisation. It's really important for what we've done to, not be duplicated out there as well. So it's an internal and an external thing. And as I said before, reducing polypharmacy. So we know that polypharmacy can be the lead for certain adverse events, such as falls or a lot of other interactions. So if we don't need, if a person is on more medications than they need, it puts them at risk anyways. So this, again, coming back down to that safety and quality element. And minimising impact from care. So this looks at virtual care, hospital and the home, obviously the flow-on effects from that when they're appropriate to the patient and what the patient's needs and preferences are, has the potential to reduce travel, use of water, electricity, PPE resources, etc. Impacts from care. So again, Eugenie, very relevant, but some of the ageing infrastructure that healthcare has, we know that has an impact on some of the effects on the environment. So even being stagnant and not even using greenhouse gases like nitrous oxide can be leaking into the atmosphere by untended physical environments that aren't being appropriately upkept. And procurement for safety and quality. So when we're making those decisions around what should we be procuring, what should we be spending our money on, making sure that there's an opportunity for the safety and quality elements to be coming into those decisions. And in a moment, we'll be tying together what quality looks like and why sustainability is a part of quality right now. So the Commission has done some work in some domains of describing healthcare quality. It's not the only sort of framework of describing the domains of quality of healthcare. We know that Victoria's actually got a framework. There's a lot of frameworks internationally as well. These are the sorts of domains that the Commission has landed on in order to navigate some of the resources and attention that we're drawing to specific areas across our work plan, but also what we're seeing in terms of safety and quality issues across the sector. So those first 5, safe, effective, person-centered, accessible, and integrated, are those domains that we understand that the workforce have direct impact over. So that's what care really should be to be effective, to be high quality. And then from a systems lens, looking at healthcare being equitable, efficient, and sustainable. So this framing really is sort of the way that the Commission is navigating driving high quality healthcare, the delivery of care, with sustainability being one of those, but also if you drill down to each and every one of these, there is an element of sustainability impact from them as well. And so for a lever for change, and sort of what had led us to be thinking that the module might be a way to navigate that, is to look at the low value pathways of care, to look at the National Safety Quality Health Service standards to say, you know, what is it there that we're already working with and what might we be able to adapt? So we know that low value pathways of care have an attention, have some real estate in the NSQHS standards, and really driving towards evidence-based care. And so that could be looking at using the Commission's clinical care standards as a model of care that is evidence-based and up to date, really looking at better patient outcomes, because when we know that the practice guidelines are aligned with best practice, we know that the resources that we're using are the resources that the evidence tells us make an outcome. And that's an important navigation tool for us to make sure that the care we're delivering does have the impact that we're hoping. And as we mentioned before, that sort of disconnected care and the integrated care systems, with the information being available at the point of care, really important. And it does drive, when we don't see that with that disconnected care, we see extra resources, including clinician time, being used inefficiently, which then leads to further resource waste and impacts on the environment. Cue the sustainability module. So what did we do? In early 2022, we conducted a literature review, or we asked a group of people to conduct a literature review for us from Monash University. We looked at the primary things that were affecting safety and quality in sustainability and resilience. And we worked with a small group of subject matter experts to come up with what actions would be required of a health service to start thinking about what could an organisation be doing to make sure that changes that could affect sustainability, environmental impact and resilience, or the climate risks, what framing would that look like? We held a public consultation in 2023. We had over 800 responses. In terms of Commission responses, that's not bad. We had over 1,000 for NSQHS 3rd edition recently, but 800 is a pretty good amount of engagement, and we had glowingly positive responses. The people that weren't so convinced were the people that wanted to know, well, how do we do it? What are we going to do? How is this all going to work? So it was just confusion. Which is great because that's a space we can step into quite easily. We had over 50 health services participate in a pilot in 2024, and what that looked like was essentially giving that to health services to say, hey, what do you think that, how do you think you would meet these actions, and where do you think you would need some extra support? And so we gained a lot of valuable insight and some refinements to the module as well from that. And then in 2025, after taking it to our standing committees, so they're committees that look at primary care, private hospital sector, as well as our jurisdictions, so each of the states and territories and the Commonwealth. And we received endorsement from all of those, and then approval from the board in 2025, and consequently published. We learnt a lot from the pilot. A lot of it was around, there was a lot of activity in small pockets of health services, but not all of those pockets were connected up. Lots of lessons being learned in different areas, but those lessons and the frameworks of nurses, clinical leadership, people on the ground, not able to necessarily use the infrastructure, the processes and the systems that the organizations sort of had in place. So sometimes we would see really good amounts of effort in pockets, but occasionally because a person would move, and that might be a person involved in the project or a person that sits on top of that project, like a manager or an exec, because they moved, we actually saw a lot of movement from that as well. So the key takeaway from this is actually in implementing these things, it makes sense to try to make sure that we're making it possible for the people that will take over from us in the future are going to continue doing the same things that we've done for the project to make sure that it's sustainable long term. And obviously a big thing that won't surprise anybody is that resourcing allocated to coordinate and monitor these strategies was a huge factor. And so when that stuff dropped off, it really dropped off the permission that people felt that they had to do some of these projects, but also the space that they had to do that within as well. There's always competing priorities. So unless you've got that champion, unless you've got that point of coordination, sometimes it was a bit of an uphill battle. And also the number of sites that had different levels of maturity in terms of their experience with sustainability strategies varied pretty greatly. An impressive site you can see there started in 2010, but a lot more sort of around 2022, 3 and 4. The module is 5 actions. They're actions for framework, it's a framework of actions for services. It aligns with the structures that we use for the NSQHS. So those are the standards that are used for hospitals. And it aligns also with the National Health and Climate Strategy that I mentioned before. So just briefly going through what those 5 actions look like. It looks at the governance and culture of an organisation in Action 1. It looks at identifying the clinical processes, practices and services that have impact and redesigning those in Action 2. In Action 3, it looks at using indicators and measures to make sure that we're making a difference, but also making sure that we're improving patient outcomes as well. So not just trying to track what our impact is on the environment, but when we're making those changes, ensuring that the patients are also benefiting from that as well. Action 4 is around empowering and training the workforce to make sure that they can do this stuff. So some of that was in the fact that people didn't understand what sustainability meant and what impacts were. But a lot of the time it actually meant they didn't know how their quality improvement frameworks could be engaged with. They knew that it was somebody else's job, that they might have to go and speak to them, but they didn't know how to actively participate. So that was another really interesting finding from the pilot. And Action 5 looks at making sure that we're engaging with the workforce, consumers and the community to communicate all of this stuff, but also back to the governing body. So the people that are in charge of making the decisions around patient safety and quality. The Commission has a number of resources. I'm just aware that I'm rambling a little bit. I've just seen the time. So the Commission has resources on a number of these things that I touched on in the module. And some of these things might not be obvious, but at the heart of them, they impact the number of resources that are being used and the impact on the patients as well, to make sure that we're having a conscious use of resources. And so we've got a couple of resources that are listed there, in addition to the fact that the standards provide that sort of overarching framework for people to be working within. Implementing into existing systems was another challenge that we put to pilot sites. We didn't give pilot sites a hugely long time to do some of this investigation work. So it's completely understandable that some of them didn't get to the point of integrating with their existing safety and quality systems. But we've done some work and put some heads together on what are the existing responses, so the safety and quality systems, frameworks, etc., that services should already have because they're meeting the standards. What could they be looking for to add sustainability principles, resilience principles into those, to make sure that we're not creating extra systems for the sake of it that might be difficult to maintain and sustain, but really embedding it in the way that we're delivering care. This is the future state, but for assessments to the module, it will not impact accreditation, but it will be done at the same time as accreditation. So what this means is that a service that undergoes an assessment with the module will be assessed as usual by the assessment teams. But in addition to that assessment and in addition to the accreditation, awarding of accreditation, the 5 module actions will be assessed against this maturity scale. And so the maturity scale really looks at how mature the organisation is at implementing and understanding, sort of evaluating the strategies that look at sustainability and resilience, but then also how they've managed to scale it. And when we're talking about scaling it, we're saying if you've been able to do it in one area, one ward, one clinic of your health service, how successful have you been to be able to bring the backbone of that across the organisation so that you're all working and not having to reinvent the wheel? I think that's a really important part to achieving success in sustainability. We don't have the time for some of this stuff to be reinvented. We need to be making sure that we can scale. And it's anticipated that those assessments will be able to start from 2026. And again, it's an organisation that would have to opt into this. We've written to health ministers, and several of those have endorsed the module, which is excellent. So this is what assessments will look like in the future state. The Commission's work on sustainability. So the sustainability module is just one part of it. I mentioned before that those models of care that we've got with the clinical care standards are evidence-based. They give you a set of indicators that you can use to improve or know that you're improving by measuring for the impact you're hoping to have, integrating certain things like quality registry data to know that the outcomes are also being followed up further down the track. And what you might want to be tweaking in terms of your models of care. Sustainability in terms of accreditation won't be impacted until 2030. However, we've conducted the first round of consultations on third edition, which is the next edition for the NSQHS standards, so the standards used for hospital accreditation and assessments. And overwhelmingly, we've heard that sustainability needs to be part of it. So between now and 2030, the healthcare sustainability and resilience module will sit as an add-on, not impacting accreditation. However, in 2030, following the sort of appropriate consultation and feedback, we're expecting it will. And so the period between now and 2030 is going to be really important for people to be trying this stuff, getting it wrong until they get it right, getting it wrong until they start feeling what is it that matches their the priorities, the strategy for those health services to be bringing this into something as a business as usual to the way they deliver care rather than some kind of additional add-on. From 2030 onwards, there's likely to be some kind of a consequence from it. So we don't want to get to that point without having the proper support in the lead up. And just as a sort of a broader step back, the Commission develops a number of different safety and quality standards across different sectors. The NSQ PCH is one for primary and community healthcare standards. This basically just illustrates that even though we will have by 2030 the elements of the module incorporated into third edition, it will still continue to be there for the other sets of standards in other sectors that we develop standards for. So the module will not evaporate, I suppose, in 2030, but it will still be maintained until those other sets of standards are updated and through consultation embedding sustainability and resilience as well. And that's it. I'll hand over to you, Joanna, or back to you, Eugenie.
Wonderful. Thank you, James. It's just really inspiring to see what the Commission has done. And I know there are probably people on the online here who have been part of that, and to see where it's going. And we'll have questions at the end, but 2030 might seem a long way away, but when it comes to accreditation, it's probably fair to say that it's not actually that far away of big health services and small. Okay, so thanks for staying on till the end and for questions. And I invite all the audience to think about some questions to ask both James and Joanne Milne, who now we have from Mercy Health. She's the sustainability lead at Mercy Health. Slight change from the program where we had Michelle, but they worked closely together and developed the presentation together. She's been working on sustainability initiatives for over 2.5 years with Mercy Health, and now plays a key role in the strategy and planning team, focusing on embedding sustainability into organisational frameworks and programs. And Joanna has a background in data management, which is fascinating. And she also therefore leads the monitoring and reporting of environmental performance. So thank you, Joanna. And thank you for stepping in.
No problem at all. Thank you so much, Eugenie, for that introduction. It was very kind. I'll just make sure that we're all good. You can see my slides. Fabulous. So thank you for inviting me along today to talk, and thanks, James, for providing a really informative presentation for us today. Yeah, it was really fantastic. So I'll be talking about how we piloted the draft version of the module at Mercy Health around this time last year, and we were one of the 50 health services that participated in that pilot process. I would also like to acknowledge the Wurundjeri people on whose land I am on today. So I'll kick off with an overview of our approach to piloting the module, looking at our scope, the objectives and the general process that we followed. So while the module required registering one site to be the pilot site, we adopted a broad whole of health services approach. We chose to do this because while we have 2 separate health services across the Melbourne metropolitan region, many of our functions operate centrally. Our objectives in piloting the module were to test the module was fit for purpose and provide any feedback where we thought there were opportunities for improvement, to assess the maturity of our readiness to meet the module's actions. Obviously, it's still a while away, but we wanted to get an understanding now. And we saw that participating in the pilot, we saw it as an opportunity to engage in a national community of practice. And finally, we just hope to gain insights that would inform our next steps. The process we undertook, it involved consulting with clinical and operational leaders, quality improvement and enterprise risk representatives across both health services. And we also undertook sort of a high-level review of our governance and operational systems, and we reviewed documents, policies and procedures. So this is a bit of a summary of our pilot process from actions 1 through to 3. So for each draft module action, we focused our assessment on specific frameworks, governance structures, committees and documents like policies and procedures. This process helped us identify key findings, including what we're already doing well and where we have gaps that will need to be addressed. From our key findings, we were able to make specific targeted recommendations for action for our health services to address those gaps in the key findings. As an example, for Action 2, we looked at our current clinical governance structures, our quality improvement program, and policies, procedures, tools, and templates that one would reasonably expect to contain sustainability considerations. And we found that we have limited use of existing clinical and operational governance systems for identifying processes with high environmental impact, and that there are opportunities to use existing mechanisms to embed sustainability in a systematic way. This led us to our recommendations for addressing Action 2, which includes leveraging the current clinical governance review, embedding sustainability lens into our quality improvement program, and incorporating sustainability considerations into major decision-making tools. So things like business cases, things like that. This brings us to actions 4 and 5 as well. Again, we use the same process of addressing, assessing specific focus areas, identifying key findings and making recommendations to address them. We found that a big gap for us is making use of our consumer engagement program. So while consumers are actively engaged in other areas of the business, consumer awareness about and participating in our environmental sustainability initiatives doesn't occur at all. So that was a clear opportunity for us. And we have, however, had some success in workforce engagement, and that tends to be quite strong in the nursing and allied health workforce. So taking the full assessment into consideration, we were then able to think about what we're currently doing right now, and what comes next for us in responding to the module. So right now we're engaging with senior executive, clinical and operational leaders across our health services to socialise the module and let them know that it is coming in the future. We're also building connections with key business functions that are important in the module. So for example, we're working with our communications team on a renewed sustainability communication strategy, and that's to mobilise our workforce and increase the visibility of our work. We're also working with our data analytics team to develop internal reporting capability, and that will make sure that we're able to monitor not only our emissions, but also the impacts of our SUS-QI initiatives that arise from our quality improvement program. And finally, we've also partnered with the Sustainable Healthcare team at University of Melbourne to implement their sustainability toolkit for health services. And we believe that implementing this toolkit will help address a number of findings and recommendations we found during our self-assessment. So, for example, we're making inroads into building our SUSQI capability. We're participating in the Health Services Sustainability Competition as like an engagement opportunity for staff. And we will also be taking inspiration from the project tracker in that toolkit to help us monitor our environmental sustainability projects and initiatives across all our health services. The next stage for us is really formalising our response to the module. So the finalised module, like James was saying, was released quite recently with some changes arising from the feedback from the pilot process. So our first next step will be to review the recommendations that we initially made against the finalised version of the module and prepare that for executive support for actioning those recommendations. And from there, we will develop a joint action plan to ensure organisational readiness for the module. And we're also drafting our next environmental sustainability strategy with an accompanying framework. And we hope that that strategy will respond to some of the module sub-actions, particularly in regards to sustainable models of care and quality improvement. I'd also like to share some of the challenges we faced and some reflections from participating in the pilot. So our team, the sustainability team that drove the pilot process sits centrally and strategically in the organisation, and we don't have close connections to the clinical care setting. And piloting the module made it clear to us that asking for shared ownership of sustainability in the clinical settings might be a bit of a challenge in the future. They may not understand why we're doing this, or what we need to do. While we have made some strides to implementing a sustainability lens into our quality improvement program, we're still a little unclear on how we're actually going to link sustainability into our quality and safety governance and committees. And a final challenge that we faced was a lack of forward thinking and curiosity about the module when having discussions with some key stakeholders. With the mandatory assessments of the module, so in the standards still quite a few years away, the focus in some of these areas remains on the present, and that resulted in minimal engagement in the actual pilot process. To my reflections, one of them was the module really provides an overarching framework for assessing our maturity in sustainable healthcare. We found that there was some overlap between some of the draft module sub-actions. So it's quite possible that one recommendation may address multiple module requirements. So you'd want to choose an action that's a bit bang for buck. And we feel that the release of the module has filled a bit of a gap in the sustainable healthcare space. So we view it as quite a key external driver for us for change, and it acts as a bit of a stick rather than another carrot. And participating in the module was a learning opportunity for my team, and we learnt quite a bit about the assessment and accreditation process. We're also in a more informed position. And we'll be approaching conversations with executive, clinical and operational leaders in a different way, I think, in the future. And finally, we believe that being proactive to the module is much better than being reactive. While assessment isn't mandatory, I think taking action now will prepare us for the future. We won't have so much work to do later on. And that's all. Thank you very much. I will take questions at the right time.
Thank you. Thank you very much, Joanna. And if you want to stop sharing your screen, I think that is, yes. Great. So we have a bit of time now. We've got about 15 minutes for questions. And if people could raise their hands, that would be excellent. Any questions for James or Joanna would be great. Get some conversation going here. And yes, thank you, Ben.
Thanks very much, James and Joanna. Great presentation. Question for James to start with, and I suppose maybe you can't give too much information or details away on this, and obviously Mercy Health were a star performer, but were there any particular health services that really performed extremely well? Is there an opportunity to maybe publicly learn from what the high performers are doing? As you were saying, we don't have time to reinvent the wheel on too many of these things. Yeah.
So the answer is yes. What we're doing at the moment is we're looking at some ways to try to. So what we know is that when a good sustainability strategy comes out, sometimes everyone sort of pounces on that organization, and because there are some really good ideas out there, and the simpler ones tend to be the better ones because it's eloquent and you can adapt it. So what we're trying to work on at the moment is trying to get a minimum amount of information from some of these services that can help other people steal their ideas, replicate it for themselves, and understand what things that they would change about their approach if they were going to try to do it again. So it is something that we're working on in the background, but trying to come up with a midway frame to make sure that it doesn't mean that people sort of see that and then okay, I'm going to go straight over to them. What is the amount of information that we can get that won't inundate that person, but will give them some couple of steps to start investigating, what does that look like? Interestingly, though, I think a lot of people that entered the pilot were really focused on, and there's nothing wrong with this, but it's just an observation, really focused on the built environment. And I think that there's a really big opportunity for the built environment to support some of these things with safety and quality. I mean, you see new builds of hospitals all the time not engaging with the way that healthcare is run and the way that models of care are delivered, and some really small things that can sort of be opportunities that aren't being built in when you're doing the new builds. So I think there's definitely linkages, but a lot of people are sort of looking towards those physical things because it gets a little bit difficult when it comes to making changes in models of care and the way that we're delivering care, because we tend to be risk averse rather than trying to manage some of those risks actively and proactively. But yes, there is a plan. But also welcome, if people want to share their stuff with us, we're very happy to give platform to that as well. We're just trying to figure out a structure that's going to find a middle ground.
That's excellent.
Thanks.
And it's good to hear, thanks, that you are going to continue to be that sort of central conduit, potentially, the Commission. And Vanessa's got a hand up, but first I might just continue on from that, because Joanna sort of talked about the challenges of, from her perspective, engaging the clinical clinicians in the clinical environment, and you've touched on that as well, James, and whether either of you had more to add on that, because obviously those models of care, clinician involvement is fundamental, and I think a lot are only just beginning to realise that how we practice our healthcare is very important when it comes to both sustainability and resilience. Did either Joanna or James want to comment, or how do you foresee down the track clinicians, and by that I don't mean doctors only at all, but multidisciplinary clinicians becoming more involved in this area, apart from the ones that are online and already engaged?
I can comment briefly, and I mentioned it a couple of times in my presentation. I think the sustainability and quality improvement methodology could be a really strong lever to do that. So we have a foundational program that we send all kinds of clinicians to, and we've been able to start embedding the concepts of sustainable healthcare through that. So I think that's one lever that health services can use. Further down the track, who knows? We have a clinical governance review happening at the moment, so we might try and tie in with that. But yeah, it's still quite unclear to us what it's going to look like in the future. Yeah.
I think maybe and this is very much a principled approach because not a healthcare deliverer or anything like that, but I think the ability to act now and to embed sustainability needs to be something that you can do within your scope. So if you're making change or planning decisions, that's your opportunity. And I don't think it should be at every single point, because additional fatigue on change, on decisions is not what we're trying to do here. But stepping back, and when we're making purposeful change and we're planning some of those decisions, that's our opportunity to be like, is this going to be something that's going to impact the environment? Is this going to be something that helps provide access to healthcare in the future when there might be disruptions? Having those sorts of principles to add in, because otherwise it's exhausting, right? But if we're going to be changing our clinical decision support systems to, add further variables, for instance, or collect information that brings things together so that we're making smarter decisions, thinking about those sorts of things. So I think it would be useful to think about the bang for buck concept that Joanna talked about, and lifting it up a level, so that when we've got the time and space to do it, let's do it then, and do it within our remit and add that voice. But yeah, I think there's a lot of activity at the moment that seems to be sort of penalizing people that aren't doing the sustainability option there and then. But you don't want sort of rash decisions to be made outside of consideration and evaluation.
Okay, great.
I think.
Yep, excellent. Yeah, no, that's really good things to think about. Vanessa, thank you.
Thanks for hosting, Eugenie and James and Joanna. Thank you so much for your presentations. A lot of us are getting on the bandwagon and voluntarily signing up to the module. Joanna, I'm really interested in your experience. Mercy's got a pretty well-developed sustainability kind of ethos and function. How much additional work was adding the module to that in comparison to the work you were already doing?
Saturday night.
That's a great question. For us, thankfully, it sort of slotted beautifully into the conversations we were already having. And I feel like we were right at the cusp of needing something like this to work on and focus on. I think, yeah, for the past couple of years, a lot of our work has maybe been on like the decarbonisation side of things, and not necessarily looking at the clinical the impacts of clinical care on the environment. So it came at a really good time for us. Yeah.
Good, excellent. Are there any more questions? Please do put your hand up. Otherwise, I can ask another one. We were talking about how the maturity rating system is going to start in 2026, which is exciting. And just wondering if you both had, well, first of all, reflections on, in my mind, I think that would engage hospital execs, even though it's not becoming mandatory, the fact that that is going to be part of the Commission's, not accreditation, but when they come and assess a hospital. And maybe, Joanna, you might comment on that, because it appears having some difficulty at some points in engaging your executives or senior clinicians. My other question was then to James, are the assessors going to have some special or extra training when it comes to actually rating this new module? Or maybe Joanna first.
Yeah, I think the maturity scale will definitely help sell, like participating in the assessments for the module, particularly because it's not just a pass or fail. I think if an exec hears we pass, okay, well then there's no more work here to be done. If we fail, okay, well, that's so much work to do. If we understand that we're maybe halfway up the maturity scale, it will show them that a lot of work has been done and there's not much left to go. So I think that will be very useful for us. Yeah.
Yeah, so good there's a rating system that encourages.
Yeah, exactly.
Will that become public? There we go. It's a question for both of you. I don't know, James.
I'm not sure.
I don't know yet. So, I mean, I think it makes we designed it to move away from the met, not met, because we know the way that sort of lands sometimes. And the idea is that we want people to be thinking about not just necessarily getting an overall, are you accredited, are you not accredited, but so it may pan out that an organisation gets an overall maturity rating out of the sub-maturities, but it's 5 actions that will be rated as maturity. So it gives governing bodies, executives insight to which areas are they more mature in. And we know that some of them are, some of them have got their governance down, some of them have got no idea what they're doing with measurement, and completely the opposite way around as well. So it will give them an understanding about where they maybe need to draw some more attention and potentially resourcing. That's the intention. How it lands is going to be something else. We've got some stuff to learn from those. So the Commission launched the Clinical Trials Governance Framework, which is also using that maturity scale. Some of the lessons we've learned from that and the feedback that we've heard is that some of the ratings were being inconsistently applied due to some of the ambiguity around what that looks like. So what we've done is we've been really deliberate with what we're talking about when we're talking about maturity. So we've got that concept of the evaluation. Has evaluation happened? So we're not expecting that a lot of the sustainability strategies have sort of lived for long enough in a lot of services to even get to that point of a high maturity level, because you're still testing the waters. You're still figuring out what's working and what's not working. You haven't made the right mistakes yet to figure out what's going to make it work. And then on top of that, once you do, are you able to scale that? So it's not just, it shouldn't just be one ward that is, carrying the back of an entire service, or like a clinic that's doing really well, whereas another one doesn't. We're looking at the scalability of it. So we're putting some objective metrics in there to support inter-rater reliability. Although at the end of the day, I think the feedback on the maturity is going to be something that can be used rather than a sigh or, a dismissal or something like that. So it sort of inspires use for it. In terms of your question, Eugenie, about the additional information for assessors, two things. So yes, there will be, but what they won't be trained on necessarily will be the 101 on environmental sustainability and climate resilience as it relates to the purest topics. So it's not, we're wanting them to still be looking at the delivery of clinical care. So we wouldn't want them to be getting to the point where they're evaluating sort of kilograms of carbon dioxide or some of those things, but we will be expecting them to see that organizations are using some form of measurement, some metrics to satisfy themselves to know that they're getting to an area of desired impact. And so we can't eliminate everything, and getting too precise about some of this stuff is going to be beyond the point. But we're going to be basically bringing that ethos to them, and then basically those principles. So where there's opportunities to embed it, we're going to be asking them to sort of look at those opportunities and give that as feedback. Again, we're all still, working through what this might look like, but at least there's a framework that we can work within. And then we're sort of working towards that third edition in 2030, where that will become a lot more prominent. Yeah, that's the anticipation.
Yep, so probably learn as that develops over the next
All of it's a
few.
learning journey. So yeah, so we'll be doing it with you guys.
Great. Andy, got your hand up there. Thank you.
Hi, thank you so much, James. I'm from a medical research institute. So what is really interesting to me is that on your website, which, generally we wouldn't refer to because being an MRI, you do have a clinical trials governance framework there. We had Madeline Skellern come out to the Institute a few years ago, and she said that from a government perspective, medical research institutes are considered part of the health system. So I wondered, do you think, twinkle in anyone's eye about potentially including some guidelines for us that will be mandated at some stage, because we need sticks? And, do you know of anything like that on the radar, or is there an opportunity for me to say that without any of my superiors knowing? Make that suggestion.
So now about the last part, I can't guarantee anything on that one, but I guess the idea that we've got space in that clinical governance trials area. I mean, the reason that started coming up was the fact that a lot of health services had those spaces in them, but they weren't applying the same things that were keeping patients safe. And so we wanted to make sure that there was a level of integration of that clinical governance across those areas. And like, not wanting to be a Debbie Downer about it, but I think there's a lot of work in that space to try to bring that into the fold. But But I think that with third edition, there's probably an opportunity to look at what you can use that framework to apply to. So we know a lot of services are using NSQHS at different editions in different sectors. We've gotten a little bit better at making them for a little bit more refined. And they tend to come from areas of interest or areas where there's something bad that's happened, but the structure will remain the same. So those clinical, I mean, you can use the module alongside the clinical governance trials framework and the NSQHS. So the entire suite of commissions work is built to be integrated across, which is kind of the benefit that we can sort of use this as an add-on. But even in spaces, so another area that I've got is digital mental health. There are some things that it won't apply to, like wellbeing services, but we still say this is a framework that you can go and use in approaching the way that you're delivering care. Even though it doesn't fit our accreditation sort of model, you've still got the framework that you can use. So I think it's probably a little bit of space that we can do to try to join the dots in that space, Andy, but it's something we can take away.
Okay, great. Thank you. Okay, well, if there are no further questions, I think we'll wrap up the meeting. And thank you once again, James and Joanna. It was absolutely fabulous and so relevant to have you both present today, and a great way for us to finish off 2025. And I encourage everyone else to look out for our grand rounds again in 2026. And thanks St Vincent's for co-hosting with us. It's been really a pleasure working with everyone. So thank you very much. And all the best for the rest of the year.